Going to be very interesting. Even I find this topic very interesting because we all use statins left and right in our daily practice. But non-statin therapy, like statins and beyond, which we call beyond statins, what lies beyond is a not that much explored area. So today we're going to talk about this. And so as we all know that cardiovascular disease has reached dramatic proportions in our country, especially in the South Asians, and prevention of cardiovascular disease, especially the primary prevention, because as I say, prevention is better than cure, has also assumed paramount importance. Statins, we know, are the cornerstone for primary prevention of cardiovascular disease, and the various guidelines have recommended statin therapy for primary prevention of disease according to various factors, depending upon whether it's primary prevention or secondary prevention, depending upon various risk markers. So I'll not go into detail. And even the Lipid Association of India guidelines, they have divided all the risk markers into three categories. One is major risk markers, high risk features, and moderate risk features. And according to the presence of one or the presence and absence of these risk markers, patients are categorized into these 5 categories. See low risk, moderate risk, high risk, and very high risk. And if you see on the right side extreme, this extreme high risk, extreme risk category is one addition which the Lipid Association of India added to the Indian population because of our propensity for having, very high propensity for developing coronary artery disease. So this is an extreme risk category which we will not find in the other guidelines, because we as a subgroup has very high propensity for developing cardiovascular disease. And just a word about CT angio, because a lot of people come to us in the OPD that I got my CT angio done and it revolves such and such calcium score, whether I should take a statin. They gave me statin, whether I should take it or not. So as they say, if you are a high risk, high cardiovascular risk, secondary prevention, very high LDL, secondary prevention, diabetic with the age 40 to 75, you definitely become a statin, you fall in the statin benefit group. If you are a low risk, definitely we can just wait and adopt other lifestyle measures. What happens if you are in an intermediate risk? If you are in an intermediate risk and you are not diabetic, this is for primary prevention, then they say that CT coronary angio is a tool to further risk stratify whether you will be benefiting from this particular therapy or not. If you get a CT angio done in a risk factors to risk of 7.5 to 99.9, and the CT score is more than 100, statins are recommended by the guidelines. If it is less than 0, you don't need statin therapy, and in between 1 to 99, statin therapy is favored. You can still, you may benefit from it, but not that strong recommendation. So just a word about CT angio, how to use this as a clinical tool in defining the risk of the patient and probable benefit from the statin therapy. And again, going into the lipid goals, as I said, extreme risk, very high risk, and according to the risk categories, the lipid goals are very stringent. If you see on the extreme left, extreme high risk, the lipid LDL cholesterol and non-HDL cholesterol goals are less than 40 and less than 70 milligram per deciliter respectively. And so on and so forth. If you go into the lesser risk category, 55 and 85 in very high risk, 70 and 100 in high risk, 100 and 130 in moderate risk, and 100 and 130 in the low risk. So very stringent LDL cholesterol goals and non-HDL cholesterol goals. So how do we achieve them? We have been using statins for them. But as we all know, that statins have their own problems. So many patients, they just discontinue. The prospective cohort says 50% of the patients discontinue statin in the due course of time because of one or the other reason. Perhaps the nocebo effect, perhaps they have some kind of a muscle symptoms or whatever. And then, even if they keep taking recommended doses of statin, many of them do not achieve LDL cholesterol goals. So genetic variability, inter-patient variability, absorption issues, and metabolic issues leads to patients do not achieve their LDL cholesterol goals. So here comes the role of non-statin drugs, because the guidelines say that failure to achieve LDL cholesterol goals is a major impediment in the in reigning this malady, which is cardiovascular disease. So one should always strive for achieving the LDL cholesterol goal as recommended by the guidelines. So just word about high intensity, moderate intensity and low intensity statin therapy. What is high intensity? When we are expecting 50% reduction in the LDL cholesterol level, it is high intensity. 30 to 50% it is moderate intensity, and we are expecting less than 30% LDL cholesterol reduction, it is low intensity statin therapy. And then, as I said, a lot of reasons for not achieving LDL cholesterol, and physician inertia is also one of the very important reason we are not able to achieve LDL cholesterol, because we just put the patient on a atorvastatin 10 milligram or rosuvastatin 10 milligram and then just forget about that we have to follow up this medication, 4 weekly, 6 weekly interval, titrate the medication, up titrate the statin therapy and try and achieve the LDL cholesterol, because we just don't bother about achieving the goals. We just put the patient on the statin and just forget about it. And so here comes so the role of non-statin drugs, that despite taking some patients the full dose of statins, or some patients who are not tolerant to statins, what do we do about such patients? A lot of drugs have come up in the last few decades. Let us talk about them one by one. So if we start from the top of the table, that is bempedoic acid. I'm sure all of us must be using it in regular practice, but this is something easily available, cost effective, and oral administration. Then inclisiran has been introduced for last few years, and a lot of talk has happened about this particular molecule. PCSK9 inhibitors, that is evolocumab and alirocumab. Ezetimibe we have been using for a long time. Bile acid sequestrants, niacin, fibrates, and omega-3 fatty acids. So these are some of the non-statin molecules which we will be discussing one by one. So how do they act? So this is a very scary kind of a diagram, and I'll not go into much detail, just few words that about the common molecules. This is bempedoic acid. Do we have a laser? Okay. So this is bempedoic acid, right? And so bempedoic acid is a molecule which acts upstream of where the statins act. Statins act on the HMG-CoA reductase, and upstream there is an enzyme called ATP citrate lyase. Bempedoic acid inhibits this particular molecule. That's why they say that bempedoic acid plus statins, they have a synergistic effect, and the combination therapy has 15 to 18% additional lipid lowering, LDL lowering effect. And then if we see these PCSK9 inhibitors, alirocumab and evolocumab, both of these molecules are monoclonal antibodies. What they do is they just go and kind of attach themselves to the PCSK9 protein. Now this particular protein is a notorious protein, because it is what it does is it goes to the LDL receptors, binds with them, and degrades the LDL receptors. Now this degradation of LDL receptor leads to failure of uptake of LDL and increased level. So by blocking this PCSK9 protein, the LDL receptors, they remain a good amount of intensity on the cell surface, and LDL uptake is increased, and that is how they lower the LDL cholesterol level. So on and so forth, the various molecules, they act on one or the other pathway, and whereby they exert their lipid lowering effect. Various trials have come up starting from 2013 up to 2014. I will not go into detail. Some of the landmark trials are SPIRE, Odyssey trials, and then you have the Fourier trials, Improve It. So the various molecules which we will be talking shortly, they have been tested in this randomized control trial, and most of these trials have come up with some evidence which points towards their use, practical use in the clinical scenario. So ezetimibe, as I said, again we have been using this molecule for quite some time, especially in combination with in statins, and it inhibits the NPC1 protein and reduces the cholesterol absorption at the intestinal level, right? So this is one protein which helps in the transport of the lipoproteins, and by inhibiting the NPC1L protein, it inhibits the absorption, and it reduces by monotherapy reduces 18% of the LDL cholesterol, and combination therapy reduces almost 25%. What are the side effects? The side effects are, nasopharyngitis, myalgia, sinusitis, extreme pain in the extremities, upper respiratory tract infection. These are some of the side effects of ezetimibe. And doses, we all know that 10 milligram once daily, and it can be taken irrespective of the meals and may be taken any time of the day. And no dose adjustments is required, especially in the hepatic and liver impairment. And bempedoic acid is a prodrug, as I already discussed. It acts upstream of the HMG-CoA reductase at the ATP citrate lyase level, 18% LDL reduction and high sensitivity CRP reduction, and it has got no effect on the triglycerides and lipoprotein A levels. And again, no dose adjustment is required in hepatic and renal impairment if it's not advanced renal impairment or advanced hepatic impairment. And hyperuricemia, nasopharyngitis, and one particular side effect which one should be watchful of is tendon rupture has been reported by use of bempedoic acid. It is cheap and well tolerated option. So PCKS9 inhibitor, as I said, they just go and block this PCKS9 protein which degrades the LDL receptors and thereby increases the density of LDL receptors on the hepatocyte, which leads to the increased uptake of LDL and thereby reduction in the LDL cholesterol level. And inclisiran similarly is an siRNA molecule which doesn't act to the PCKS protein. It actually stops, it goes into the PCKS9 gene and stops the PCK9 production. So again, the inclisiran is given 6 monthly subcutaneous and leads to almost 50% incremental LDL reduction over and above statins. So gradual onset and sustained effect on LDL lowering. On the other side, the monoclonal antibody which we just discussed, evolocumab and alirocumab, they have immediate action, and they have to be given more frequently, like bi-monthly or once a month subcutaneously. But inclisiran is a more gradual onset of action and can be given 6 monthly. So this is the basic difference between these two types of PCSK9 inhibitors. So basically the use of inclisiran is not recommended in the routine clinical practice except in the setting of heterozygous familial hypercholesterolemia and homozygous familial hypercholesterolemia, because a lot of issues, subcutaneous administration, injection site side effects, and also high cost of the therapy is barriers to using inclisiran. So PCSK9 inhibitors and then bile acid sequestration, as we all know, they go into the intestine and bile to the hepatic bile acid pool, thereby reducing its reabsorption, and thereby the liver has to work more to produce these bile acids and then consume the cholesterol, because the bile acids are produced from the cholesterol, and thereby leads to increased LDL cholesterol clearance from the bloodstream. We know that we have cholesterol, cholestyramine, and cholesevelam. They have got different doses. Like cholesevelam is given 6 tablets per oral daily or 3 tablets per oral twice weekly, and similarly cholestyramine and cholesterol. And mean LDL reduction is with monotherapy is around 15%, and with additional 10 to 16% if used with statins. Phytosterols, we know that phytosterols are molecules which chemically resemble cholesterol, and so thereby they compete at the intestinal brush borders with the cholesterol for absorption. So thereby the ingestion of phytosterols actually leads to reduction in the cholesterol absorption and thereby reducing the cholesterol levels. Then there is soluble viscous fiber. Again, soluble viscous fiber reduced to low absorption of the cholesterol, because it kind of acts at the micelle level when the chylomicrons are formed in the intestine, and thereby reduces the absorption of cholesterol. The effect on LDL cholesterol is modest, not very high, but still they say that it is one of the most cheapest, easily available, and one of the most health-friendly, gut-friendly option available as a non-statin therapy. And mipomersen and lomitapide are two more molecules. Again, what mipomersen does is it blocks the production of ApoB100. We all know that ApoB100 is a major apoprotein for this bad cholesterol, the LDL and the VLDL. All of these have the ApoB100 as a major lipoprotein. So this is by acting as an antisense oligonucleotide, mipomersen blocks the production of ApoB100 and thereby reduces the production of the circulating levels of ApoB containing lipoproteins, that is LDL and VLDL. And similarly, lomitapide, it inhibits the microsomal triglyceride transfer protein and thereby has more effect on chylomicrons and VLDL, right? And also leads to reduction in the LDL cholesterol level. LDL apheresis, I'm sure this must be a little kind of a new term for all of us. And they say that some patients, especially the patients with familial hypercholesterolemia, even despite giving intensive statin lowering, LDL lowering therapy with statins, high intensity statins, PCKS9 inhibitors, and ezetimibe, bempedoic acid, all those things, despite they have very high cholesterol levels, those are the patients whom can be actually referred to LDL apheresis, which actually selectively removes this ApoB100 containing LDL particles from the bloodstream. They will have a drastic reduction in the LDL cholesterol level. So LDL apheresis has got its own select indication in select patients, and that's very useful, especially for those patients who suffer from familial hypercholesterolemia. Omega-3 fatty acids and omega-6 fatty acids, we all know that EPA, that is eicosapentaenoic acid, and DHA, that is docosahexaenoic acid, they are basically found in fish oil and green leafy vegetables. Similarly, omega-6 fatty acids. How do they act? They basically, we all know that they have anti-inflammatory properties, membrane stabilizing properties, plaque stabilizing effect, and also they have got marked lipid lowering effect in the form of decrease in the triglyceride-rich lipoproteins, apoprotein B and apoprotein C3. So that is how the omega-3 fatty acids and omega-6 fatty acids, they have a lipid lowering effect. So this is just a general idea how these various group of drugs, what is the quantum of their effect on the LDL lowering. If we see the ezetimibe, roughly 15%, the bempedoic acid, 24%, moderate intensity statin, 30% lipid lowering, LDL lowering effect, high intensity statin, as I saw, almost like 50%. And if we go to the bottom, when you combine all these therapies like high intensity statin, ezetimibe, PCSK9, you can achieve almost 90%, 85% LDL lowering. So we have a lot of tools in our hand. The idea is, the question is how much we use them. The idea is to put them into practice. We have a lot of things in our hand. If somebody has a 300 milligram per deciliter of LDL, you just imagine 90% lowering. That means we can bring it down to 30 milligram per deciliter, but we should be ready to use the tools available in, as the patient demands, as the patient clinical status demands. So putting all this information into clinical practice, let us just go through a few case examples very quickly. So this is a 58-year-old gentleman, hypertensive, had a non-STEMI 3 years back, has an LDL level of 92, HDL of 38. What should we do about this man? Anybody from the house? Should we give him low intensity statin, moderate intensity, high intensity, no statin, fibrate, non-statin? No statin, why sir? He already had a non-STEMI 3 years ago. So any patient who is already has a clinical atherosclerotic cardiovascular disease, he falls into the preview of secondary prevention. All secondary prevention patients have to be treated with high intensity statins. This is the recommendations, right? So there are 4 basically statin benefit groups, which definitely the guidelines say that you have to identify these 4 groups which will definitely drive benefit from giving statin therapy. One is clinically present CAD. Number 2, LDL level more than 90, this irrespective of diabetes, hypertension, clinical cardiovascular disease. LDL, very high LDL, that means. So clinical CAD, clinical cardiovascular disease, LDL more than 190, diabetic patients between 40 to 75 years of age. The third, 40 to 75 years of age. And if nothing is present, then the next 10-year risk of having cardiovascular disease should be more than 20%. So these 4 particular subgroups will definitely benefit from. These are called statin benefit groups. So in this patient, definitely we will start the patient on high intensity statin, review after 4 weeks, see whether we have achieved our goal, which is 55 for LDL and 85 for non-HDL. If the patient is still not on goal, add ezetimibe 10 milligram. And then again reassess after 4 weeks. If the patient has still not on a goal, then you must considering more non-statin drugs like bempedoic acid or other drugs. So this is how one should be, not just putting the patient on a moderate intensity statin, just forget about this. So this is how. So another example, 54-year-old man had acute MI 3 days ago had received a stent. LDL is 120 milligram. How should we go about this? So acute coronary syndrome, LDL 120.
So there is a LDI study now, recent study, where all the 3 drugs was started in acute MI. After Monday, first day the reports came, and they benefited in long run, and target LDL was below 50.
Yes, sir. So this is improve IT study, right? Improve IT study. They said that even in ACS patients, one should aim at early combination therapy rather than monotherapy. In ACS patients, because this is the highest risk, subset. So in these patients, not only monotherapy, but early combination therapy, and as Dr. Atul said, very stringent control of LDL levels, because that has been found to be beneficial as far as MASI or the major adverse cardiovascular outcomes are concerned in the long run. So again, the picture shows 40 milligram rosuvastatin, 80 milligram atorvastatin plus ezetimibe, early combination therapy in ACS patients, then re-examine at 4 weeks, see whether the goal has been achieved or not. If it hasn't been achieved, then add bempedoic acid and move forward, right? So just not stop at, start initiating the statin. You have to review the patient again, see his overall risk profile, see his, likelihood of benefiting from, intensive treatment, and then decide to customize his treatment accordingly. So, but about somebody who doesn't have diabetes, hypertension, is a young man, 52-year-old, but the LDL levels are 240. Somebody walks in the OPD, he has nothing, he says, I am perfectly asymptomatic, no diabetes, no hypertension, non-smoker, no family history, but my LDL level is 240. What should I do?
Lifestyle modification and
Cascade screening of the siblings and all those things. Because these are the patients who definitely have very high likelihood of having premature coronary artery disease, malignant coronary artery disease, and these are the patients who will definitely benefit from aggressive lipid lowering, especially with non-statin agents. We have to identify this particular subset. So depending upon the DLCN score, whether the score is more than 6, potential familial hypercholesterolemia, whether it is heterozygous, then you go for cascade screening in children and sibling, lipid profile genetic testing, and then start the lipid lowering treatment with high intensity statins, ezetimibe, bempedoic acid. Patient is not able to achieve goal, add PCSK9 inhibitors. PCSK9 inhibitors has got kind of a very pivotal role in the treatment of meningioma patients with very highly raised LDL levels. So these are the patients whom we can say that we can justify our high cost of PCSK9 inhibitors, because the magnitude of benefit you're going to derive from this subgroup is really very high. So the cost doesn't matter if you are dealing with such a patient. So what are the options? We have evolocumab, alirocumab, as I already discussed, or inclisiran. Evolocumab and alirocumab are, bi-weekly doses, subcutaneous. Inclisiran is 6 monthly doses. Both are very costly medications. They do have their own, because of the parenteral subcutaneous administration, their own local side effects. But still, the amount of incremental lipid lowering is very high. So this is one way of, achieving. And still, if we are not able to achieve goal, LDL apheresis, as I just mentioned a few slides back. So specialized therapies, as I said, mipomorsen and lomitapide, or LDL apheresis. What is the role of these specialized therapies? They can be needed if the patient still has LDL more than 90, has phenotypic homozygous familial hypercholesterolemia, and despite treatment with statins and ezetimibe, PCSK9 inhibitors. So these are the specialized therapies reserved for such patients. And then LDL apheresis I just mentioned, and then ezetimibe, just one word about ezetimibe. There's these 9 particular subsets: CHF, hypertension, age more than 75, diabetes, stroke, CABG, peripheral arterial disease, GFR less than 60, and smoking. These particular 9 subset of patients, they have been found to have, derive more benefit from ezetimibe therapy rather than, adding any other non-statin. So if you have these clinical conditions available, you would just tend to add ezetimibe before adding any other, non-statin drug. So I think I can, this is just, statin intolerance. If we know that patient has statin-associated muscle symptoms, what do we do about this? If the rhabdomyolysis, no statins, significant elevation of CPK, you have to stop statins for 4 weeks. And if mild elevation, stop it. After 2 weeks, you can again re-challenge with a mild dose. If the patient has recurrence of symptoms, you shift to another statin. And some people say that pitavastatin is one statin which can be used if patient is not tolerant to any other statin. If you feel that this is a very strong indication for putting the patient on statins. And so hypertriglyceridemia, we can just skip this for the sake of time. And so just to put everything into perspective, so we see we have a patient who has an indication for lipid lowering therapy. We put the patient on lipid lowering therapy. Target goal is 55 to 70. Has the patient achieved the target? No. Then what is the additional incremental lowering we are desiring? Is it less than 30% or more than 30%? The guidelines say if your additional lipid lowering desiring is less than 30%, go with ezetimibe or bempedoic acid. We want more aggressive lipid lowering, more than 30%, then you can directly go to PCSK9 inhibitor. So this is a just general kind of a recommendation or an approach, practical approach, how to proceed, while using these non-statin therapies. And so take home, it has got non-statins have attained key status in the last few years, and it leads to targeted intervention and personalized treatment. Initial combination therapy has been found to be very useful, especially in the acute coronary settings, and expanded use of bempedoic acid for not at goal, despite using statins and ezetimibe. PCSK9s are useful adjuncts for LDL goals, especially in select subgroups like homozygous hypercholesterolemia. Thank you very much.